Our next speaker is going to be Professor Muhi El-Banna. His talk is going to be about obesity and cancer, risks and links. And I think after the end of the session, we can have some questions for discussion.
ممكن حد من المنظمين يقول لنا في سبيكرز غايبين ولا لا؟ ما احنا عارفين. دكتور محي اتفضل موجود. عايز اعرف بس مين موجود ومين مش موجود عشان ننظم الوقت.
Bismillah ar-Rahman ar-Rahim. I'd like to thank Professor Hisham Al-Ghazali for giving me the opportunity to participate in such a great conference, and I'd like to thank the chairman for inviting me to speak in front of you. My topic is the relationship between obesity and cancer, and this relationship had made big news since 2003 when Newsweek commented on a study by the American Cancer Society that showed the link between obesity and cancer. Then in 2007, the prestigious Guardian of the UK talked about a great report published by the World Research Cancer Fund on food, nutrition, and physical activity and the prevention of cancer. It's a huge report, 537 pages. Then the CNN again in 2009 commented on a report by the American Cancer Society that demonstrated that 100,000 cases of cancer are diagnosed in the United States due to obesity. Research data from the past 25 years demonstrate that obesity is the cause of 14% of cancer deaths in men and 20% of cancer deaths in women. Some now estimate that the total health burden of overweight and obesity may exceed that of smoking. If we look at the causes of cancer, we can see that if we combine obesity, overweight, dietary elements, they exceed smoking, and combined they constitute 35% of the causes of cancer. The International Agency for Research on Cancer in 2002 concluded that obesity is a cause of 11% of colon cancer cases, 25% of kidney cancer cases, 37% of esophageal cancer cases, 9% of postmenopausal breast cancer cases, 39% of endometrial cancer cases. And Wallin et al. Showed that there is a relationship between obesity and colorectal cancer, liver cancer, esophageal, pancreatic, gallbladder, and thyroid, renal cancers, non-Hodgkin's lymphoma, leukemia, multiple myeloma, melanoma, prostate cancer in men, and endometrial cancer and breast cancer in women. It has been shown in several studies that weight loss reduces the cancer risk. The best evidence comes from bariatric surgery patients. Cancer death rates have been shown to decrease by 38% over 15 years after gastric bypass surgery. A loss of about 10 kilograms or more in postmenopausal women decreases the breast cancer risk by 50% with decline in circulating estrogen. It has now been shown that weight at diagnosis affects the outcome of breast cancer management, with growing evidence that weight gain after diagnosis results in a worse outcome and a higher recurrence rate. The same is true for colon cancer and prostate cancer. Even after cancer diagnosis, patients need weight management, and there is evidence that increasing physical activity and avoiding weight gain after cancer diagnosis have substantial benefits in the terms of treatment outcome and recurrence. Senekrop et al. In 2013 showed that there is a relationship between obesity and the prognosis of colon cancer. And during a median follow-up of 7.8 years, obese and underweight patients had significantly poorer survival, significantly reduced disease-free survival compared with overweight and normal weight patients. The adverse prognostic impact of BMI was observed among men with class 2 and 3 obesity, but not among women compared with normal weight patients. They concluded that obesity and underweight status were associated independently with inferior outcomes in patients with colon cancer who received treatment in adjuvant chemotherapy trials. That study was conducted at Mayo Clinic and published in Cancer 2013. Rickles et al. 2012 showed that in stage 2 colorectal cancer, viscerally obese patients had a nearly 3-fold decrease in disease-free survival, whereas in stage 3 cancer, viscerally obese patients had a longer time to recurrence. They concluded that viscerally obese patients with stage 2 colorectal cancer are at a higher risk for poor outcomes and should be increasingly considered for adjuvant chemotherapy. The mechanisms, there are 3 well-known mechanisms now, which are the insulin pathway, estrogen and steroid hormone pathway, and the adipocytokines. Immunomodulation and inflammatory states play a role too. Adipose tissue is metabolically active. It secretes adipokines as tumor necrosis factor, interleukin-6, leptin, and adiponectin, and it secretes growth factors as insulin-like growth factor 1 that inhibits apoptosis and promotes cell cycle progression. The insulin pathway and the insulin growth factor 1 are elevated in the serum of obese subjects, and both activate the AKT PI3K-mTOR cascade, which gives an explanation to obesity-cancer connection. Another possible pathway is the inositol polyphosphate pathway. It has been confirmed in several studies that metformin is an anti-cancer agent. Metformin, known in the market as glucophage, has anti-tumor effect in breast, colon, prostate, and liver cancers. It reduces the incidence and improves the prognosis in these cancers. Adipocytokines promote tumorigenesis by increasing cell proliferation, invasiveness, angiogenesis, and modulating the crosstalk between cancer cells and extracellular matrix. Adiponectin is protective against gastric cancer, colon cancer, and liver tumors. Adiponectin is decreased in obesity, while leptin, on the other side, increases in obesity and mediates obesity-related cancer. Leptin induces cancer progression by activation of PI3K, MAPK, STAT3 pathways. Excess adipose tissue is associated with chronic systemic low-grade inflammation. Adipose tissue in the obese shows extensive macrophage infiltration, their number correlating with the level of adiposity. In case of cancer development, macrophages increase angiogenesis, tumor invasion, and poor prognosis. It has been shown that appropriate chemotherapy dosing for obese patients with cancer is sometimes difficult. The American Society of Clinical Oncology Clinical Practice Guideline, published in 2012, showed that practice pattern studies demonstrate that up to 40% of obese patients receive limited chemotherapy doses that are not based on actual body weight. There are concerns about toxicity or overdosing in obese patients with cancer based on the use of actual body weight, and these are unfounded. Body surface area of a man 1.8 meters tall and 71 kilogram is 1.9 according to Dubois formula, while the body surface area of a man the same height, 1.8 meters tall, and double the weight, 148 kilogram, is 2.55. That's only 34% higher, while the body weight is 100% higher. Body surface area dosing will result in underdosing, especially for fat-soluble drugs. Contrary to that, and the panel recommends the use of full weight-based cytotoxic chemotherapy doses to treat adult obese patients with cancer. Contrary to that, Miyahara et al. In 2013 at the Saga University Hospital, Japan, they found that in solid tumor patients with BMI more than or equals 30, the incidence of grade 3 to 4 hematological toxicity was significantly lower in patients receiving chemotherapy according to ideal body weight compared to patients receiving chemotherapy according to actual body weight. And they suggest that tumor type, degree of obesity, complications, and choice of chemotherapy regimen should be considered when determining chemotherapy dosage for obese patients. Wong et al. In 2009 found that there is a shift in delivery of external beam radiation in obese patients. The target location does not receive the full dose. The Swedish Obese Subject Study, SOS, is the first long-term prospective controlled trial to study the effects of bariatric surgery on diabetes mellitus, hypertension, cancer, and mortality. It involved 2,010 obese subjects who underwent bariatric surgery and compared to 2,037 matched obese control subjects not receiving bariatric surgery, receiving only the usual care. The effect of surgical weight loss was shown after 10 years up to 20 years. and the mean changes in body weight in bariatric surgery group versus the control group was loss of weight of 23% of the total body weight in the bariatric surgery group compared to 0% in the control group at 2 years. At 10 years, the weight loss was 17% of the total body weight in the bariatric surgery group compared to 1% weight gain in the control group. After 15 years, the weight loss was 16% of the total body weight in the bariatric surgery group, and after 20 years, the weight loss was 18% of the total body weight in the bariatric surgery group as compared to loss of 1% of weight in the control group. And the long-term effects of bariatric surgery, which is obesity surgery, we call it in surgery bariatric surgery, the long-term effects were compared to the usual care. And bariatric surgery was found to be associated with a long-term reduction in overall mortality, decreased incidence of diabetes, decreased incidence of myocardial infarction, and decreased incidence of stroke. Remarkably, there is also a decreased incidence of cancer in women, but not in men. The messages to take home are: obesity has become an epidemic and is exceeding smoking as a public health problem. Obesity causes several types of cancers. Weight loss decreases the cancer risk. Obesity surgery is the only effective method of long-term weight loss and weight control for the morbidly obese who have a body mass index of more than 35 kilograms per meter square. And obesity surgery reduces the risk of cancer and reduces cancer incidence, especially among obese women. Thank you very much.